like jelly. Then surgical airway, we'll get to that in a second. Breathing, are they actually moving air? Are they sucking chest wounds? Do you need a needle to decompress them? Do you need chest tubes? What's their oxygenation? And then looking at their circulation. If their cap refill is delayed, they might be at 20% down in blood volume at that point. So you're looking at refill. Obviously pulses. General rule, if you can palpate the radial pulse, it's 80 solid blood pressure or the arterial. And if you can feel it at the carotid, you're looking at 50. 2 large bore IVs, warm fluids, pericardiocentesis. That's, of course, when we're doing our fast exam and ultrasound, direct pressure bleeding. So when I was doing sort of the latest, on ATLS, one of the things they added, and the latest real update from the American College of Surgeons was in 2018, they added this base deficit concept. You can see that at the bottom there. And so, of course, this is the different stages of shock. And when you really start noticing the blood pressure drop, this is probably the most important thing on this whole slide, is in stage 3, when you're already 30 to 40% blood loss. And if you're waiting for that blood pressure to drop, you're waiting too late. And one of the clues could be this base deficit, which, like I said, it's kind of new since 2018. I don't know how many ABGs are doing in the trauma bay, especially if it's one of those scoop and run or just getting the metro type deals. But that could be an important indicator of how far into shock we're going. And of course, your mentation is a huge sign of shock. Sometimes we underappreciate that. We just want to get that vitals. We want to get that pulse ox, But when we're talking about somebody who's noticeably sick and they look like they're going to die, you're already at 30 to 40% of their blood volume that they've lost. And then when we're talking numbers, we're talking about 1.5 liters to 2,000 or 2 liters that they're down. And that's when your pulse gets up to 120, 140, and of course your blood pressure. Respiratory rate is also a really underappreciated indicator. If they're breathing 30 or 40 a minute and they're getting acidotic, this guy's had cramp, so he's getting sprayed. So we're still in the primary survey that we're talking about, and I'll go through a couple of examples. The disability, you're just looking at, can they talk at the very beginning, and now you're looking at, can they move their legs, just wiggle them, checking the pupils, and again, GCS is important in the airway state. Environment, disrobe them, and any kind of penetrating trauma. Doesn't matter how bashful they are, who they are, what age, you got to get everything off, roll them, look at everything, because you don't want to see that there was a gunshot to the finger, but you missed the bullet hole that's in the back. Toxic exposure is another real critical step. So you've got somebody with a blast injury, they're covered in gasoline. I had one of those. And you can't really expose your staff to important chemicals. You've got oxygen in the room. You don't want to blow up the whole ER and hurt everybody else. Of course, fentanyl was an issue, and different toxic exposures. If they're covered in white powder, you've got to detox them before you get any of the ABCDs. So then once you've made sure that they're not dying in that golden hour of pneumothoraces and pericardial effusions, and then you do the secondary surgery, you do sort of this is still ER, but you're doing sort of a thorough exam. And scalp wounds, facial instability, hemotympanium, distension, tenderness, penetrating wounds, pelvic stability, huge. And then rectal exam is kind of falling down. I'll show you that a little bit, that there's some data that the American College of Surgeons doesn't see it as reliable and important. But urethral meatus for blood, because once you have urethral meatal blood, you don't want to put a Foley in until you do a cystogram. And then checking peripheral pulses, making sure there's no vascular injuries and external deformities. So, that's enough. So again, we're in the ABCDs, and we're going to be scanning that chest likely. But why are we doing that portable chest? We need that in the ER immediately to make sure, are we doing a chest tube or not? It used to be you would do a cervical shoot through lateral on every single trauma. But with good immobilization, you can get them to scan. When they scan within 15 minutes, it's less needed. And if you have an instability in the pelvis, you want to get that x-ray or whatever because you want a pelvic binder. You can lose 2 liters of blood from pelvic fracture. Then you do your fast exam, and then get to the scanner as soon as you can. Generally speaking, you want to have 3 things in mind on every trauma, and you just decide whether you do or don't need them. That would be tetanus or Boostrix, ANSEF if they're a penetrating injury that's high risk or an open fracture, fluids, and then TXA. So these are all plus or minus. And then it used to be Pepsid based on Curley and Cushing oscillars, but that's kind of fallen out. So this is just sort of going through ABCDs, again, not doing the full thing, but just you've got somebody with a good story, 50 miles an hour, pounds of airbags, pain in the abdomen, you know, the EMS is hot, everybody's excited, it's a trauma standby, you call it, and this is what the guy looks like. So this happens so much, you know, you wouldn't believe. In fact, I had two 13-year-olds that got hit by a car. They're crossing the street, rain, jaywalking, and they got struck 30 miles an hour, you think the worst. And then the one kid, Dr. Kramer he just blacked out, had some root fractures, ended up getting transferred. My guy, he had terrible lax on his arm, but not a thing broken or injured on skin. And so you can have really crazy mechanisms, and that's what ATLS is all based on, is, you know, what is the mechanism that then gets everybody excited and activated to get these resources as soon as you can. But that's not always how they look, or when you examine them, that's what they find. So the most important thing when you this patient, that story is you can see his GCS is good, his airway's intact. You know, sometimes you get these motorcyclists that, you know, they're 70 miles an hour and they wipe out their bike. There's not a scratch on them. So then you see a different story, 45-year-old MBA, 50, you know, sort of a similar story. And now he's somnolent, blown pupils. Totally different case. So now we're back to ABCDs. If your GCS is less than 8, you got to want to secure the airway, make sure they don't aspirate their lungs, which makes trauma, the process, the illness of trauma, all that much worse if they aspirate. And with the blown pupil, it's going to be the ipsilateral, and then yeah, so I'm just going to, again, we're still on ABCs here. So here's another guy, ATV, clothesline to the neck, 125 miles an hour, he's awake, choking, short of breath, hoarse voice. Again, nurses are doing IVO2 monitor, double lines, all sorts of exciting stuff. Your priority should be airway first. And then, is this going to be an expanded hematoma? He's hoarse now, he's going to lose his voice in a few minutes from now. So he might have big broken femur and all sorts of scary stuff. He may be in unstable pelvis, but your priority is you need to trach this guy. I mean, Craig. Another way to go about it is to just preemptively intubate him, and if it's not going well, you have your Craig at the bedside. And if it does go well, great. If it doesn't go well, then you Craig him. And then, of course, gunshots to the face and things like that. So again, I'm going through these examples just to say, you know, going in order and not ignoring one step to the other. Sometimes you have an open tracheal injury, you just put the tube right in there. And then with Craig's, you know, you also want to find that you're not doing these all the time. You know, I knew a paramedic at St. Pete's that was so proud that he had done dozens of these. That's not exactly a great thing. You want to be able to intubate somebody. If you can't intubate them, you should be able to bag them. But if you can't intubate or bag them, then that's when you have to Craig. And I really love the cellular techniques. You do it kind of like a central line. You put the wire, you know, the needle, get air, put the wire in, and then you change it over a dilator, and it goes great. And I just had one of these, I don't know, a couple months ago. I've probably only got about 3 since I've been here. What was this? This was just open penetrating, same story. You know, this is somebody that they did intubate. So if you intubate and you stabilize the airway without having to do anything surgical, great. Because sometimes these surgical airways, they can be a mess. You know, lots of blood and all that. Same story, absent breath sounds. So what you see on this image looks like tension pneumothorax on that right side, their right side. But you also don't want to find yourself getting the x-ray and finding this late. You want to be able to diagnose this clinically. So you have absent breath sounds, deviated trachea, hypotension. You want to just needle that chest right away. And again, it looks like I'm really changing, going through a whole lot of stuff. I'm not even past the primary surgery on these cases. And then here's the chest tube, and then everything re-expands. So there is a difference between a simple pneumothorax. You can have 20-30%, but it's not causing any hemodynamic compromise. It's not squeezing the heart. There's no deviation of the mediastinum. But a tension pneumothorax is something you don't want to ignore. And ATLS actually even verifies something that some of my attendings taught me 20 years ago is if you can't get the chest tooth card, you can get everything ready, bunch of betadine, stab them with 11 blade, now there's a hole, now there's air going out, and this is somebody who's about to die. So if you just poke a hole, and there's pressure, it's going to come out. You don't have to get a fancy, I mean, if you have a needle decompression, that's great. But, so here's some of the updates, and like I said, the last update was in 2018, and there really hasn't been a whole lot. They're not reinventing the wheel, and not like the AHA. It seems like ACLS is always a change every single year, right? The ACLS, they really only look at it, you know, every 5 years or so, and they only change so much. So use base deficit and shock as a marker. That can be helpful. They're saying you could still go ahead with 1.5 liters of crystalloid associated with, going over 1.5 of crystalloid can increase mortality. Probably the dilutional effect, so your fibrinogen and your thrombin's getting diluted. So you want to find yourself in trauma that's hypotensive, going to blood right away. Direct pressure is still mainstay. There was one big stop the bleed thing, going to tourniquets, and that was coming out of military data, when they would just tourniquet all 4 extremities and then do an exam and then find out what the problem is and then start taking tourniquets off. And now ACLS is saying, well, direct pressure still does, and if you can. And insert transfusion if you got classic shock, and then they address TXA, saying go ahead with the TXA. So needle thoracotomy, they found that as America is getting bigger, our needles are short, too short. And they did research about that. So they were saying that all of our trauma centers should have much longer needles. So we've done that. And they also found that there is potential, or the underestimation, or the overestimation of where we're going. The marker had been midclavicular. Now they're saying, well, if you look at all the needle decompressions, they seem to go a little too medial, and you might be getting the mammary artery. And there's potential on the left side going to the main vessel. It's still acceptable, but now they're also saying you can go intercostal axillary, so on the side where you do the chest tube anyway. Blunt aortic injury is now treated endovascularly. They hadn't mentioned that before. They said high-widened prostate, which is going back to the rectal exam, is not reliably indicated, not reliably found. So they're saying it's not 100% necessary. Now, if you have somebody that can't feel their legs, you think it's cauda equina, you think they're paralyzed, rectal exam still mainstay, very, very valuable for their neuro exam. But if, I remember little kids and we're doing rectals on every one of them, and they barely have a wound on them. That's not exactly necessary, according to this update. Head injury guidelines: avoid hyperventilation, less than 25 millimeters of mercury of CO2, maintain with blood pressure. That seems pretty intuitive. Don't hyperventilate them too much. Don't overcorrect. You want to get them to 35. Spinal mobilizations, change the spinal motion restriction. That came out of a whole lot of little backwarding people so much they're getting to cubes, and head blocks, and the studies show that they were struggling and then actually hurting themselves worse. So they're saying that there's sort of a modified approach to motion restriction. And there's some discussions about remembering geriatrics and peds and smaller chest tubes. So that also, it used to be that you had a hemothorax, they said, well, it could clot off. Or if they got implanted, they had pus, then it could clot off. So you need to have a big garden hose and 42 French tubes. And now they're saying, no, it's all right. And actually some of these little catheters, these pigtail catheters, are okay in pneumothorax, because they don't really clot off. So they kind of changed their perspective on that a little bit. I don't know why I had this one in here. This is talking about traumatic arrest and about the algorithm, but we'll just say traumatic arrest is very bad. I feel like I skipped something. Okay, here's a head trauma. This is, if I remember correctly, this was in Africa, and somebody was protecting their house and stabbed him with a spear in his head. But what's the important thing about this? ABCD, right? His airway's intact, he's breathing on his own. He's mentally sitting up, or she. And also, as you probably already have heard a million times, don't take the thing out. Take it out of OR. And this is the post on the reconstruction, which is pretty nice. And this is the finish. Barely a scar after all of that. So high-level stuff on head trauma. So bright white is blood, acute blood. And so you got a little bit of acute, a little bit of chronic. It's crescent shape, so we're looking at subdural, there's midline shift. And then here is more chronic, and then when we're at 3 days is when it's isodense, so it'll be the same color as the brain 3 days out. Sometimes there's some cases of the bilateral subdural, that's 3 days old and it looks like normal because the pressure is on both sides evenly. And they have like an 8% mortality, so those are one of those killer foils. Lentiform, bright white, acute, bad mental status, that's an epidural, so mid-meningeal artery rupture. Here's pneumocephaly all throughout the brain here. Here's traumatic subarachnoid blood. And a depressed skull fracture. This was probably the operative because it's pushing at major structures. I'd be surprised the person didn't have neurodeficit there. And then basic skull fractures, which you can, it is a clinical diagnosis. So if you have the radical necromoses, hemotympanum, a battle sign around the mastoid, and then of course you're also looking for watery discharge from the nose and CSF rhinorrhea. You can check the watery rhinorrhea for glucose, and if there is, then that's probably CSF. And most of the cases that are bad are going to show up on CAT scan, you're going to see something, but they can be clinically normal, they can be imaging normal, and you have a clinical finding, they may still need to be observed, and to make sure that they don't all of a sudden have swelling, infection if they worsen, etc. Diffuse axonal injury, this is a terrible picture for this. This is a diffusion weighted image on an MRI, but you've just got a whole bunch of diffuse swelling, and then there's punctate areas that are essentially dead tissue. But essentially you don't have a brain bleed, you just have sharing of the axons on a microscopic level and a lot of swelling. And then cerebral contusions, essentially your head gets shook and it's like squished watermelon or a squished sponge. Your brain just has some blood in it, but it's not a collection that you can extract. Let's see. How do you sound like here? So this is just a demonstration of the fencer's posture. I think this is something that's underappreciated or under-talked about. But anyway, it's kind of like a post-traumatic seizure when your brain is, I like how you do that cartoon there. Well, I guess I didn't show up too well. Anyway, so you get the idea that you can get lights out and then your body's response is to put your arms up. Sometimes they're even doing automatic motions like they're punching at the air that's not really there. And that is a bad sign of bad brain injury.
Dennis Munson.
No, this is an example of a punch drunk, the double hit hypothesis. So if you're getting clocked and you're getting concussed, the most important thing is to not get concussed 2-3 times in a row. And here's an example of a young, healthy person. The whole video is too long, it's like 8 minutes, but it's an example of what they're supposed to be doing as ring doctors, what they're supposed to be looking at, and this guy was failed. And it was an ER doc that was the ring doc, and he's checking his phone the whole time, it's all on video. And this guy died. And the ref failed this guy because the guy was having the staggers, he was having an ataxia, and they continued to fight. And he got 2 or 3 more hits to the point where he just went completely unconscious. And once you have a second or third major hit like that, you're getting this unchecked microscopic swelling and edema. And it's not a subdural that you can extract, it's not pressure that you can do all the hyperventilation and mannitol and everything, but this guy died. And I'm getting the feeling like some of the things I added to this lecture are not coming through, so this is like my old version of the lecture. But hopefully I'll be able to check this in a little bit. So anyway, these are Lefort fractures. There was a physician, this was back in the 1800s, he took skulls for an anatomy lab and he just threw them off of like an 8-story building. And then he looked at what were the fracture patterns. And so they came up with type 1, type 2, type 3. And these are really interesting when you see them. They're a rare thing. I mean, type 1, obviously, it's just that alveolar ridge and everything. But I had a guy when I was in residency, had a type 2, and they ended up wiring his jaw. And so he was having respiratory distress in the neuro ICU. He had been awake and talking, but then he was obtunded, his eyes were and he's having these small respirations. But the coolest thing about it was he was breathing so hard that he was blowing air through his nose and his forehead would jut out. Every time he was breathing, it was like this seesaw face. And we had to decide, were we going to cut the wires of his jaw being shut? And as a resident, I'm like, I don't want to cut into this guy's surgery, And so the anesthesiologist came in like a cowboy and did a nasal tracheal intubation, which in trauma, one of the rules is don't do nasal tracheal intubation because you've now got this unstable, terrible fracture and you've got this tube and you could be putting it right into the brain. But it worked out. It did fine. So cervical spine, again, like I said before, how do you do all cervical spine in a few minutes? But there's certainly at the dens. So at the dens, here is over on my side. Here's a type 2. So type 1 is at the top of the dens. Type 2 is right in the middle, and then the 3 goes into the body of the dens. So as you can imagine, these are unstable and need to be fixated. Here is a perch facet, which is kind of a misnomer. It sounds like it, or sometimes they call it locked facets. And this is actually likely to be highly unstable because the subluxation is over 50%. There's this thing called the 3-column theory. So you've got the anterior longitudinal ligament, the posterior longitudinal ligament, the ligament flavum. So if you've disrupted all 3 of those ligaments, then you've got this unstable bobbly head, and those are the ones you don't want to miss. So it's not uncommon for us to have a compression fracture or a simple stable fracture, and if somebody has a surgical risk, we put them in a collar for 6 weeks and they'll be fine. But in unstable fractures, they need to be fixated. Here is an example of, there's this column that I was talking about. And then there is teardrop fractures. So extension teardrops, they look very innocent, they look like nothing. But the important thing is what it's showing is that that little piece of bone that came off was because of a major ligament that was disrupted. And so even though they look very simple, they can be very unstable. And then the one on the left is showing you how it sublux backwards. This is one of the most underappreciated things is occipital ankle dissociation or dislocation. So essentially, you don't have a fracture at all. It's all ligamentous instability, where you're actually pulling, or they also call it internal decapitation. And when I was in residency, I said, don't worry about it because they're not going to survive. You're not going to have to. There are good case studies where people that had neurodeficits, a negative scan, and if you put them in a position that will kind of reduce, will kind of cycle. So there's a few things that you're looking for. You look at the clitus and the it's the clitus, right? And it should bisect into the dens. So it should meet. There's something called the Powers ratio. You measure this to this and this to this, and you can do that calculation. And then if it's over 4 millimeters to 5 millimeters, that's too wide. And sometimes this is the kind of injury that happens in kids. Jefferson fracture at the Atlantis, C1. Can be fractured in a burst fracture, and then if you looked at a lateral water's open mouth, you'll see that these are deviated one way or the other. So it seems like most cases are going to scan nowadays. We're not doing as many open waters views. So how do we clear people? Nexus criteria, big study, it was like 50,000 people, went from 18. So you couldn't generalize it to children, but they're looking for 5 points, and if they've got this, you don't need x-rays. If there's no midline tenderness, no intoxication, their GCS was fine. If the GCS was 14, then you still couldn't do it, and if there's no neurodeficits, and if there's no painful distracting injuries, which is also another little bit of contention. So the idea is that if I don't have any neck pain, I was in a major mechanism, but I have this terrible open femur fracture, well, you're gonna not tell me, you're not gonna be able to tell me if your neck hurts because you're so distracted by this terrible, overwhelming pain. So sometimes you look at somebody who has toenail pain, and you're like, well, can I clear them or not? I have a little finger pain, can I clear them? So So then people came up with the neck pinch test. So if I pinch your neck and you say ow, then you probably know that it hurts or doesn't. And then the Canadian cervical spinal rule is actually, in studies, a little bit better, and it's a lot simpler. So it's essentially, you can look at it at MD Calc, but it's a three-step process. If they have any risk factors, and if they can move their neck, then you don't have to do radiography. I don't know why this kid was just smearing himself ice cream. It's like my kid would do that. All right, so now we're in chest trauma. So here, this is a real case. Look at that guy on the left going back, and he looks fine, and then he's down. So this is a case of commotio cordis. I don't know if this guy survived, but this is similar to the football player that went down. Was it 2 years now? So it's essentially like an RT phenomenon, and if you've already, it's like doing a precordial thump. And usually we're doing a precordial thump to start the heart if they're in VTAC or SVT or something, or VFib. In this case, you have a normal heart, and then you got punched into the heart just the right time to send you into an arrhythmia. And then the treatment would be electricity. So that can happen in a healthy person. And then it also brings the question about when there's myocardial contusions. So you got somebody that has a big chest trauma, everything else is fine, ABCDs are fine. You do some cardiac enzymes, and their cardiac enzymes are up. And this 20-year-old has never had coronary disease, and their EKG looks fine. What do you do with that? Do you observe overnight, watch on telemetry? So that's it. Again, you're getting troponin elevations, bumps, you get a functional myocardial injury, even though they're healthy. And it's usually transient, usually they do fine. Ribs. So here's an example of flail segment, and then you get paradoxical movement. So as you inspire, you want your chest to expand, but then the segment is freed up like an island of ribs, and then it sucks in. And if you get a big enough flail segment, then you're not going to be able to ventilate oxygen very well. Oh yeah, so here's my ambitions. So this comes out of maybe the last, there's actually this literature is going back 10, 15 years now. But it's really catching up with American College of Surgeons and saying, you really have to, for us at Fire Ambulance, we should address this. And I'm getting down essentially to the comorbidities of rib fractures, that maybe we've been underappreciating these for a while. And I'm getting down to baseline for a patient admitted with a rib fracture is 10% baseline mortality. But it can increase with each additional rib fracture approaching 40% if greater than 5 ribs. I don't know what that is. So, especially if you're older than 65 and you have comorbidities like COPD and everything, if you have 3 or 4 rib fractures, that's kind of a big deal. And we scanned you and everything looks fine, it's not a flail segment, you're oxygenating fine, your pressure's good. I mean, in the old days, we say, okay, it's going to hurt. I'm going to give you a bucket of pain medicine and send spirometry. I want you to have a good follow-up. But now, that demands a trauma consult. And that doesn't mean that necessarily have to be admitted, but it has to be entertained. And ACS is kind of saying that maybe we should be admitting everybody 3 ribs and up, especially the comorbidities. And then just a couple of little tidbits, up to 14% can have a pneumothorax that might be underdiagnosed. Always think about non-accidental trauma in children, and rib series are only 67% sensitive. So sometimes you don't get a rib series at all, or you do and it's negative, and you say, you're still playing tender, I think you got a rib fracture. But now places like the big trauma centers, they're doing these rib scores, which is the chest trauma score and the rib score. And if you got over 3 or over 4, then again, you should be maybe admitted to a progressive or ICU, because we're anticipating you having respiratory failure. And the place where I trained at St. P's, now they're doing, they do one of these 2 scores at the beginning, and then they're doing the daily scores every single day in the 65-year-old with 3 rib fractures. And they'll catch these people before they crump, before they become a met and get intubated and put in the ICU. And it can reduce unanticipated ICU admits 60%. Which, when it goes to surgery, the flail chest wall deformities, respiratory failures, multiple severely displaced. I just had somebody that fell 8 stories, and he broke literally every single rib on his left side. He was pretty stoked about it, but I could tell he was in a lot of pain, but he was a tough guy. And we sent him to Metro, and they literally opened him up and repaired and plated every single rib. And he did great. Open pneumothorax, so you got a big open hole, and so as you're breathing in and breathing out, blood is squirting out. So you can get a blowing chest wound. This was supposed to be a video, but it's not doing it. And then sometimes you can have exposed lung tissue coming out. I remember Dr. Iskowitz and I had one when I was maybe my second or third year here. Somebody with a drunk neighbor came over with a machete. They were both drunk. They were both fighting, and the guy just sliced him. And it was this right side chest.